We're working on, for those that are on the phone that can't log in the webinar, we're going to tell you in a second what the login is. It's the first one full.
And then,
so this is how we're going to do. While they're working on that, we're going to do. Camille and I are going to go through the presentation. These are essentially our thoughts on a slide, or where we would, where OVH and the department would like to see the crisis system potentially go. We are open to feedback. We're open to comments about what doesn't work. Almost everybody in this room understands the ground level pretty well, so we are eager for that feedback about like that absolutely won't work, or there's an issue here, an issue there. So we'll take a moment after most slides to take comments, questions from the room, and then we will take a pause and take the question. Kristen will read questions from the webinar as well. How are we?
Okay, so if you guys need, if you have somebody who's texting you, or if you will have somebody that's texting you or emailing you that needs the webinar link, I'm going to ask you to send a real quick email to Liz Owen, and it's liz.owens@state.co.us, and she will send you the link. So she's waiting for you, and she'll send out that link. I have it right here. I'll go ahead and type it into the webinar, also, so that if you guys need, so if somebody needs it on the webinar as well.
How many people we have on the webinar right now?
There's 22 on this one.
And then there's supposed to be there's 100 on this one, so
the 122 the first one's full. Everybody got that? If someone's texting you that can't get on, they need to get on the second webinar. We'll can we send the invite? The invite, or there's no invite?
So it was just an email.
Sorry about that. So the first couple of slides, we're going to get started because I don't think anything in the first couple of slides is going to really require the visual. Well, maybe not. I could be wrong. So if you're on the phone and you're not able to get on the webinar, and then you go through the slides, you have questions. We'll pause and go back to that and make sure we get the questions in. We are recording the webinar, and we're going to write everything down so that anybody in the world of that's interested in crisis, when the RFP comes out, can go online and look at this. This will not be a conversation about the RFP specifically. Move the first slide. So on the bottom here, all technical questions related to RFP will be in the pre-bidders conference after the kickoff for the RFP for the crisis system. We wanted to share, as most of you probably already read the crisis report, we're just going to share some high level, we're not going to redo the whole report on what the crisis steering committee and recommendations they have. The department's already started the process of analyzing what and where we can get funds for some of the recommendations, as well as what steps we can take for the recommendations. I don't know if we've identified any necessary legislation yet from the recommendations from the steering committee. We're going to outline specific changes that we would hope to see, we would like to see as far as the system structure for the crisis system. And we're trying to do this in enough advance that we can have a really in-depth dialogue and conversation. And we're not rushing towards the end of the fiscal year. So with that, the next slide. This is just, if anybody was at the crisis committee, steering committee, you know we put up the legislation, and I'll give you a quick second if you don't know these. Statute actually has some requirements. It has culture, the crisis system must have culture competence, strong community relationships, the use of peer support, the use of evidence-based practices, building on existing foundations with an eye toward innovation, utilization of integrated system of care, and an outreach to students through school-based clinics. So I don't think there should really be any questions on that. I'm just reading what statute is. On the next slide, you'll see the the numbers. It's just a high level of numbers of services. Camille, I don't know if you want to talk any more about the numbers for this slide.
No, this is really just a summary of fiscal year 2017 and then our complete fiscal year, and it shows some high-level utilization for each of the modalities as well as by region. So this is just a snapshot of what that current sort of utilization looks like.
And these will be on the website, right? So, any questions about utilization numbers? These are not individuals, these are services provided.
I'm wondering how this ties in.
Raise your hand, sorry. Yeah, go ahead.
I'm John, and since I see this on encounters, how is this identified?
Yeah, these data are reported to us.
You gotta repeat the question.
Oh, so the question is, this is a question from John, who works in rates at HICPUF, and it's around utilization, and it is the question is this encounter data? And this is not encounter data. This is summary data that's reported to us by each of the vendors, the current vendors.
Okay, and then so how are you identifying crisis services in these? Is it based on a modifier or?
Yeah, we're not using encounter actually. This is aggregate data that's reported via spreadsheet to us primarily. Yeah.
Okay.
So these numbers are reported by the vendor.
Yeah, you can ask further questions about encounter and data submissions further on in the presentation. And I may have to defer.
Fair enough.
But I'll do my best.
Questions so far? All right.
Okay.
Questions on this one? Okay, go ahead.
On two questions. The first is, so the folks providing the services, they are required to input information on any walk-in, any crisis that, whether it's mobile or walk-in, they're required to put it in a specific database, and that's how you're collecting this. Is that correct?
It's an Excel sheet, right?
No database. So current sort of state.
Well, but they have their own EHRs and their own database, I'm sure, but when they submit to us, it's not good data.
Thank you.
Yeah, so the question is, how does the data come to us? And I was just going to do a tiny bit of level setting. So the current contractors are CCC, NBH, SBCC, and West Slope CASA, right? And so they have providers that are largely community mental health centers who document in their own native EHR, and then those vendors report into an aggregate spreadsheet. They have, the contractors have staff that do that, and then the data comes to us via spreadsheet largely. There is other collateral data that we collect, but we can get into that later. But that's what these data are. Thanks.
Anything you want to add to hotline data submission?
It's real similar. We have our own data forms that we fill out, and we also submit on activity and
Really driving home the 1984 model of Excel sheet.
Speak up.
Speak up, sorry.
I won't tell this.
And you can stay right, those are my.
Oh, you know, we got to repeat the question too, sorry. Go ahead.
So from my understanding, under the mobile crisis services, that includes visits to emergency departments. Do you have a separation of visits to the actual community versus patients already within a service? You know, that's separated out at 66,000.
You want to repeat your question?
Yeah, so let me just repeat the question as I understand it. So the question is, so how are we able to tell when mobile response is occurring within an emergency room versus any other community-based mobile response? And so our current way that we collect that is in the aggregate spreadsheet. Separately, we do get encounter data. So the claims data has a place of service code on a claim form that allows us to say, like, this service occurred in an emergency room versus this service occurred elsewhere. And so we do know that about 35% of the crisis utilization in the last year that we looked at, it was largely delivered in an emergency room. And so we can continue to walk through that. And we do have some additional slides that are related to data further down in the slide deck. So if we want to move on and get through the large content, and then we can get into some of the weedy questions that I think most folks might have about the current system.
So that actually leads very nice to the next slide about the 10 recommendation that the crisis committee talks about, that the data and technology portion of the crisis system is not very strong, particularly between other systems that are providing services and the crisis system. So there's, yeah, I mean, we're using Excel sheets and it can't really tie encounters together. So from other systems, so that is something that was recommended and highlighted in the committee. Some other things highlighted in the committee is would like to see an increase in breadth and depth of services for youth and children. That was one of the two key areas that was mentioned around children's services. We do appreciate and understand that the $30 million for crisis right now, dollars. We're talking about all kids in the state. It's not probably going to cover everything if you do adults and kids. So we do understand that if this is a conversation that needs to continue, we need to identify all potential funding sources, and we need to work with child welfare and other child-serving agencies to talk about how we can intersect and interconnect these different systems that are serving children and providing behavioral health services. The second key area, these are the two most voted on areas for focus, was peer support. Folks really want to see a heavy investment in using peer supports in the crisis system. Leveraging technology, I mentioned that one on all fronts. On the hotline front, on the data submission front, on being able to follow a client or a consumer throughout their care, making sure the care is continuing, making sure that we're able to hand off information so that the continuing care, and if we reduce the frequency of crises in the future for that person, those are all areas that were identified, and that technology, hopefully, and we can reduce the amount of time, paperwork time, and administrative time that clinicians are spending by use of technology was another preference as well. Number 4 was how is the other. It says co-responder model and mobile services can work together in crisis. So we will have 12 co-responder models that we are funding throughout Colorado, where law enforcement and behavioral health are working together. That intersects very much with mobile response. So how do those two working together and having a more formalized process? I will say this. Through the crisis committee, it became really clear that the department and OVH specifically, we've got to write stronger business rules and expectations about what we would like to see, because it's not really fair to the vendor to say after the fact, these are all things we're looking for, but we didn't get delivered on, but we never stated it, we never wrote it down, we never established that as an expectation. So going forward, things will be really wordy, but we'll really make it clear what we're asking for so that we can have a fair dialogue, and from the get-go, there's a clear understanding where we are at, what we would like to see for the crisis system, and not expecting people to guess. So, but the co-responders thing, I think, that's one area where the crisis system is, we feel like we're duplicating a little bit. I also know that some counties have community response teams that they're funding. So how does that tie in with co-responder? How does that tie in with mobile? Really trying to, end of the day, reduce the duplication of efforts and figure out how it interlocks. And I don't think it's a fault of anybody. I think that's how, unfortunately, at times government operates, right? We move. Some people are moving quicker than others, and some people will have ideas, and they found a funding source, they want to work on something, and taking the time to stop and say, who else is doing this, and how can we make it connect? Is a really key question that you got to kind of carve out that time in your day or in your week that most of us don't have. All right. The next one is develop an implement and outcome evaluation system. This recommendation came from the committee, really saying, okay, we have an evaluation today. It's not complete. So the evaluation has been done.
Yeah, but it was only on a portion of the system.
Only on a portion. Okay.
Yeah.
So there's just a holistic kind of return on investment concept, and how are we doing? How is access to care? How are we doing? Are we reaching all the folks that we intended to reach? Is the system working quite the way we want it to work? Going back to the business rule thing, the way we want it to work needs to be clearly defined as well. There was a desire from some to establish a leadership committee, just sort of, continuing the stakeholder input ongoing, which is good for any scenario, including consumer input. How do we make sure that this is not occurring just every 5 years, but occurring as an ongoing basis, and folks can weigh in and let everybody know what's working, what needs tweaks, and what needs to be attempted. And that's sort of, I think, straightforward. I think that's an area that shouldn't require any money, and that we could easily do and should do. I think it's not fair hearing anecdotal stories for anybody in a community when we really need to come together to one spot and give folks chances to hear an anecdotal story and be able to respond and what.
Can I do a pause really quick?
What do we got?
Just to be clear for everyone on the phone, if you joined late, Dr. Robert
Sorry.
Lazar is speaking, so you want to introduce yourself for the people who are a little late.
I didn't introduce myself to the room.
Yeah.
Dr. Robert Lazar. Oh, not Dr. Robert Lazar, you call me Robert. I am the Director of Office Behavioral Health. You want to introduce yourself too?
Sure, Camille Harding, I'm the Division Director for Community Behavioral Health.
And Kristen and Chris are manning the webinar. Do we have questions on the webinar yet? No. All right, I'm going to move this along because I don't think this is why everybody came here. I think most people read the report already. Improving integration in services of mental health substance abuse disorders with our stabilization units. There is a task force today where there are some people that are on that in the governor's office working to make licensing a little more pragmatic. I think that's music to everybody's ears in this room, and trying to. We all know here that mental health substance abuse are interlocked. Our licensing requirements should do so, and we believe we can make improvements to the licensing so that service can be delivered, particularly in smaller communities where one provider can do both, but we're making it really hard for them. If we can do that without jeopardizing the safety of the patient, that's what we are looking at. So really looking forward to that. I think in November, the recommendations. I'm looking on December 1st. What's that? December 1st, those recommendations should be out. Statewide integrated data and resource system for the hotline, we talked about that. Implement targeted marketing for those populations not served by the crisis system. At the end of the day, I think everybody in the committee felt like we need even more robust marketing than when we have the funding for the crisis system, half of what the child welfare campaign funding is for their hotline. And in the world of TV ads and all that, 600,000 doesn't get you all that far when you're trying to reach the entire state of Colorado. Exploring and using a 3-digit number for crisis line. This came up in committee, and so it happens. It also came up federally. So was that bill passed or was it introduced?
So the bill is passed, it's on the president's desk, but what the bill asks is that the FCC, the Federal Communications Commission, do a cost-benefit analysis of the use of a 3-digit number. So 3-digit number is guaranteed. It's just an exploration, and I anticipate that those will probably take about a year to come out. So it'll be a little bit of time before we have that federal direction.
So this probably will be the national talk line, moving to a 3-digit number as that direction it goes. It's a really good recommendation in the sense of how many people in the community are going to remember the 10 digits, and almost everybody calls 1-800 instead of 1-844, or they call 1-877. They don't know which number they're calling. So we get that a lot. So those are the recommendations. The report is on the website that I have. Yes.
Yeah, sorry. So then it's the recommendation, this recommendation kind of like, first we're going to see the analysis from the federal level. Was there agreement among the stakeholder group, the committee, that would be weighted on maybe as a priority until after we get that guidance for the cost benefit analysis at the federal level?
Yeah, the recommendations explore for that reason, for a couple of reasons. One, all the 1-1 numbers are all taken. So I don't think we're going to wait for the federal to explore. I think we're going to do our homework in the meantime. We've already started, including talking to Arizona, but looking at 2-on-1 options. Can we work together with 2-on-1 or not? I think we're going to work in parallel, but I don't know if we execute without knowing what direction the feds are. I don't know if that makes sense to execute without knowing what the feds are going to do. All right, great. Yeah.
As the example number 4, where you were talking about the crisis response teams, the co-responder model, the other types of mobile response, because it wasn't prescriptive in the initial, what happens is communities were able to problem solve and solution in different ways. And so my question is that is the intent of the RFP to maybe usurp some of that innovation, partnerships, resource alignment that's happened locally, or will it truly be able to be what you're saying, which is let's recognize what's out there, make sure that it braids and interfaces appropriately and connects well?
So how about we do that? How about we hold the question on what the intent is around co-responder and mobile, and we can talk about the program. I can't talk about the RFP, so we're going to phrase questions. It's going to be, what's the intent of the program going to look like, not the RFP going to look like.
And just a repeat of the question real quick. Sorry.
Yeah, the question had to do with co-responder, mobile. What's the intent? How do we make that work? It's sort of how I heard it, but we're going to hold on that because I think the later slides get to that question. All right, next slide. Here are some changes that were based on the recommendations that you just made. that we're looking for. One, maintain 5 modalities that exist today. There was no desire to change the modalities that existed. This is the key one. Administrative service organization approach. We at OBH and the department would like to see the crisis system go in a direction where we contract with a vendor who builds a network or builds adequacy of services. It's not extremely different than what's today, but it's not defined that way today. So we would like to define it similar to a lot like what we do with the MSOs. We do with the MSOs, we pay the vendor, and most of you are probably familiar, but I'm just going to summarize at a very high level. It's an MSO structure. We pay the MSO. We say, here's our outcomes, our targets that we would like to see. Here's the money. It also makes contracting much easier when new money comes in. And we say, go build the network, right? And I don't know what Durango needs. I don't know what Pueblo needs. I don't want to have to try to figure it out. I want to work with my entity that's responsible for administrative services in that area to subcontract with providers to build an adequate network. And that's the big shift that you're going to see today that we're going to talk about. I think it gets a little bit to the way you're talking about how you do that. If you go into a county and they have a mobile system already set up, an ASO can say, instead of trying to build more resources and spend more money here, are you willing to come to the table and maybe we can both put money into this community response team that you already have, right? And then I could focus efforts in a different county that has nothing, right? That's the kind of, it allows more flexibility in contracting. All of you probably contract with the state at one point. It is burdensome, it is difficult. There's a lot of state fiscal rules. This makes it much easier and quicker for folks to get services going on the ground. At the end of the day, that's all we want. We want to know that people throughout the state of Colorado can access these services, and they don't have to wait for a contracting process with the state through our fiscal rules to do so. So I'm going to pause there because that's sort of a big shift from what we require today, and see if there are questions in the room, and then we'll go to questions on the phone before we go forward. And I'm going to start from this side, and then we're going to go across. So if you got hands up, we'll start right here.
Thank you, Debbie Stafford. Can you just clarify, is the intent to maybe take existing crisis services and help them strengthen areas where they may need to strengthen, or is the intent to sort of throw the baby out with the bathwater and start over? Repeat the question.
So you're asking, is the intent? So you're asking if the intent is to build upon who the vendor is today? Is that what you're saying?
That is correct.
Okay. So the intent is for anybody who wants to bid for the RFP, right? That's really important. So our intent is not to any specific vendor, right? Our intent is strong applications for the RFP. I think we're getting, so that is the strongest applicant can win. I will say this, and we do get to this later. My intent for the ASO is to work with all providers in the community that are capable of providing crisis, particularly those that have been invested in, and those that have the capacity today. I don't want to wait 2 years for capacity of crisis beds. So I let you interpret that how you want. We're getting to an RFP area here that I don't want to get into because it sort of ruins the RFP process and makes it an issue. I'm a big fan of people working together and saying, I can offer this and you can offer that, and let's figure it out. An ASO structure, let's talk about the MSO structure. I'll talk about the MSO structure because it's not something we're RFPing at the moment. So, or intending to at the moment. So before anybody jumps to anything. The MSO structure, the MSOs have flexibility in the providers they can identify, particularly in the community, right? So an MSO structure, and they can decide, you know what, Pueblo really needs this residential services, the community of Pueblo. I'm hearing a lot of feedback of what the need is. I can provide it with a contractor, and there's some conversations about adjusting goals and what we've asked for, but it gives flexibility. I don't see a whole lot of let's create new providers, right? I see a lot of let's work with who exists in the community and who wants to contribute. So that's where a lot of my questions are going to be like this because I don't want to get into the RFP. I want to make everybody eligible, and but I'm a big component of not reinventing the wheel. How about that? Okay.
Hi, Sarah Baines from Summit County Government. I am wondering about.
Hold on, real quick. Am I good with procurement? All right.
I think it's great.
Just go like this if you're like, shut up. Okay, thanks.
I think it's great to have flexibility within communities. Not every community needs the same thing. But I'm wondering how you will ensure that the MSOs are making decisions based on community input and what the community needs. I feel like a lot of, not just behavioral health, but healthcare in general is arranged around who pays for what. And how do we know that the MSOs can make decisions based on community need and not how the money flows?
That's a great question. Well, you mean the ASO structure?
Sure.
Yeah. What do you guys do in the MSO structure for community input?
So, yeah, I step out of the room and all of a sudden we're talking about.
I'm sorry, on the phone, the question is about how you community input for the ASO structure, and it's very similar to the MSO structure, so I asked Daniel about how the MSO structure that they get input from the community.
So I think number one, it is a perennial item of emphasis that we have to continually focus on and recognize that we're never going to have the information that we think we have. We need to continually have that fight. Oh yeah, sure. Sorry. One of the big things that we've done around a new investment that we have from the state legislature that we call SB 202 funding is that requires us to perform a community action plan. So we're connecting with communities, with organizations on a recurring basis on an iterative process, and those recommendations and expressions of need for how those funds should be invested are what those funds are then invested in. We have then a process that we use to solicit provider agencies to be participants in offering those services to the local communities. The big issue is there's far more need than there are, right? Even with the wonderful additional resources we have, there's far more need than to accomplish all those things. And I think we always have to get better about being sure that we have everybody connected to the process.
And I think that Daniel's saying somebody's always disappointed.
Can you introduce yourself to the telephone?
Sure. Daniel Darting with Signal Behavioral Health Network.
And I want to follow up with that. That is important to us too. So as going forward, it is an expectation we'll have about how do you get community input into the process. We're also mindful of that when we start thinking about the timeline between an executed contract with whoever wins and July 1st when the services get started, about giving time for everybody's input. And there are stakeholder feedback opportunities during the RFP process as well. Am I good?
Can I just say one follow-up thing? I just think it would be good for the ASOs to be thoughtful about what they mean by community input. And sometimes the community input is all of the vendors, or I just want to make sure that there's community input coming from all areas of the community.
Noted, and we'll make a note of that. And then on the later slide, we have some comments on specific stakeholders that we'd like to hear from. We're going to go there and there. Did I miss anybody else over here with, other than Jason, with a question? All right, Jason.
So Robert, one of the questions I have regarding the ASO is that if it mirrors the MSO arrangement or even the RAID arrangement where it's built by different regions to be able to make sure that there's enough awareness of what's happening through an area, is there right now a vision to be able to have several ASO arrangements or one statewide, or do you not know
We're going to do a regional model.
And do you know how the regions are being broken up, or visions to be broken up?
Yeah, we would like the program to go to, here's, first of all, we got a lot of feedback from legislators over the last 2 years. They're tired of seeing different boundaries. So first off, we would like to see similar boundaries, and it's going to be going forward for the next couple of years for all of OBH funding. We would like to be in line with healthcare policy finance on boundaries, right? May not be providers, we'll do a competitive process, but boundaries will be similar. So if you think about right now, it's the RAID structure where the boundaries are drawn. We want to draw similar boundaries for a number of regions, and we'll get to that. I'll go through in more detail the region concept in a slide that's coming up.
Can I make a recommendation? We've got like 4 slides specifying what the ASOs are, so maybe before we start asking these questions, we can go through that.
Are you bidding out for an entity to become an ASO?
Yeah, so
Nope.
I know, I got you. What we're not bidding for is we don't have any preconceived notions of who those entities are.
That's part of the art.
Programmatically, we want to align regions statewide so that geographically people are having not diverse services across the state. So they're getting healthcare services for their physical health in one region, crisis is elsewhere, right? So aligning the geographical regions programmatically is the decision.
This does not apply to hotlines. Sorry, hotlines, the goal for the program going forward is to maintain statewide process for the hotline. So we are talking about all the other four modalities, what we would like to see going forward as a program. All right, I'm going to go quickly because Kristen's right. We do have a lot. New standards for mobile. If you read the committee report or you were part of the committee, you know what this means. This means that we really would like to, like I said, we need to establish the business expectation up front. And up front is heavy emphasis on community and preventing people needing to leave their home or needing to go to the ED or needing to go to jail. That is really where we would like to see an emphasis. We do know that sometimes the ED and other places are necessary, but we would like to see an emphasis and priority given to mobile, and we would like to see mobile as the shining star of the crisis system. That's the way I can put it going forward.
And sorry, one more, just to move things forward. So this is an overview of what we're going to talk about today. Let's go ahead slide by slide so that you can have a note. Yes, okay.
So same thing for the walk-in crisis stabilization, setting up business rules. And when this gets procured, there'll be a lot more detail on that. Crisis line I mentioned is going to be, we want to keep statewide a lot about we would like to see technology advance and we need to identify funding to help technology advance for the crisis line. Same for respite, we really like respite. We think this is a respite going forward is a key component for children particularly, and keeping children at home. And this is where we need other partners in other areas such as child welfare, counties, youth services, probation, really coming together and having a really robust conversation about let's keep kids in their home. As a state, we are not great at this, and I would really like us to get better, and here's an opportunity. And also, what other funding can we identify to strengthen that? All right, next slide. Any questions on the thing that are not going to be answered?
Nope, they were answered by the people here.
All right.
Thank you.
I mentioned maintaining the 5 modalities. I said the crisis line are being statewide service with no, so this portion, as it is today, of the modalities, the crisis line modality will not require medical necessity. Crisis for the hotline purposes is self-defined. So if a person feels like they're going through a crisis, they need to talk to someone, we are not discouraging anybody from calling. We want everybody to call and to talk to the professionals, to the trained professionals on the hotline who may be able to mitigate the issue over the phone. Mobile walk-in CSU and respite services will be, we do want, as a program managed by an ASO. So that is what we would like to see for all the reasons I mentioned already, and I'll get into. We do need to follow the statutory definitions of 2760 that was mentioned, and we mentioned those already, right?
Okay.
OVH identified additional funding for youth and social services, as I mentioned. We got ways to go. I'm a big component though. How do we know what to invest in unless we know what we're already investing in? And that is where I would like for us collectively to sit down. Child welfare is going to a major federal reform on Children's First Act, and Children's First Act, which was funding that traditionally only funded kids who were pulled out of the home, is now being revamped. And the feds, after 20 years of arguing on this, have said we need to make funding so we can keep kids in the home and prevent child welfare involvement. So we really need to sit down as a collective and talk about what that means for Colorado and how we can collectively contribute to all emphasis of them.
The last bullet, is the funding for kids respite or the parents respite?
So the funding for, the question was, is the OVH identifying additional funding for youth and children's respite for the parent or the child? A little flexible on that with the goal, the goal for me is keeping the kid in the home if possible. And I say respite, yes, there's some respite that has a home. I would like to see an emphasis, and we can disagree on this, we can talk about this, and you can tell me I'm wrong, that's fine. An emphasis on respite that allows the kid to stay in the home.
That's what I'm talking about. So that the child can go and get support while the
tell you this from a parent perspective and from just talking to people. When there's a crisis in the home and the child is removed, there's that little guilty, as a parent, a little guilty relief, right? And not that you have to be guilty, but that's how I felt. Relief. It's much harder to get that kid back home because the parent's like, I don't see any scenario where our house is not going to fall apart. Versus the professional being there and showing and kind of helping them make things stabilize. And they're like, and it gives you that sense of hope. It's a learned helplessness, right? Most of these kids, for the rest of these, are years of struggling in the home. And if the parent identifies with removing the child as the only way to keep the child safe, then they're going to really struggle to bring that kid home. So I really would like to see an emphasis on how we get the services in the home and help the parent through this really complex and difficult situation with the right resources to be done in the home. That's not going to be true for everybody. I understand that.
Maybe this is implicit in the second bullet, but I want to make sure that I understand how it relates to the third bullet, because at this point, the walk-in centers, it was self-defined crisis as well, which may not necessarily meet the threshold of the state's definition that we've adopted as a state for medical necessity. So it's an interesting call out for that one when we do have people who go to the walk-in centers with that self-defined crisis.
That's probably an oversight on our part.
Okay.
So I think assessment, and you can kick me if I'm wrong, but we want folks who feel like they need the service to get assessed for it.
Okay.
Yeah.
Thank you.
Sorry. Questions? I know there were other hands. Are you ready to move forward? Okay. All right. We'll talk about regions. 4 regions split into 7, mainly for boundaries, for no other purposes than boundaries. And when we talk about data, and we start talking about services, and we start talking about healthcare policy, finance, and OBH, that's the only reason why we're talking about boundary changes here. I can't talk about the RFC.
More information will be provided in the RFP that will be published shortly.
Yes. Yes. Thank you.
Can you repeat that?
More information will be in the RFP when it's released about the 7 regions and using existing boundaries. Yes, I'll say that. How about that? That works.
Okay.
All right. Don't worry about me. I'm more worried that the room's more worried that we're being overly conservative, right? Just know that we'll have boundaries. There'll be regions, and people will be able to bid on those regions.
You said that the regions don't apply to the crisis plan. Will they apply to the marketing?
Great question. They want to know if the region apply to marketing. No, it doesn't. It's not. The marketing is specifically for the hotline. So the marketing will also be statewide as well. I would, though, Kristen has created a marketing committee. And I do think, and this has nothing to do with the RFP, this has to do with pooling resources as a state and making sure for marketing, we're not flooding the community with different messages and different markets when it comes to crisis as a whole. And how do we work together to maximize the message? So the message is that we have similar message, and we're not tripping up the community about who I call, when I call, and what's crisis. That I think we can get stronger on, and Kristen's created a committee where we're hoping, and on vice versa, that we can create toolkits. And when we started this, particularly for the opioid work, where we create toolkits and people can just put off-the-shelf toolkits and apply them. It's something when I was in child welfare, we did child welfare. We created sort of toolkits for counties to take and make their own, right? So they would throw their name on it, and their logo for a county event, and they would just use the same message that we developed, so they didn't have to spend money on a marketing person to develop their own message.
So the committee is for marketing across OBH, not specific to the crisis system.
Yeah, it's across all campaigns. It just makes, instead of having multiple committees, it just makes sense to do that. And you can contact Kristen Bates, Kristen with a C, CRISTEN, Bates, if you are interested in participating more on the marketing side. All right, not related to the RFP, but related to marketing as a whole. All right. All right. So we have aligning scope and location of services will allow for more direct and obvious collaboration with Medicaid. So it's kind of self-explanatory, right? With the boundaries, if we stay with the same boundaries, who's ever providing a service, whoever we pay with to provide any service period, the more consistent we are, the less people they have to work with. So if we have the same boundaries and this organization as contract with healthcare policy and finance, and somebody we contract with, so they just have to go to one person for that region instead of multiple people in a region, multiple entities, and create more layers. So it really is for the sole purpose of making it easier. And I would not like any more legislators to ask me why do we have so many different boundaries. So, all right. Next one is the goal is to have each region have access to the full continuum of services. The goal is for the four modalities to exist in each region. Like I said, though, we would love mobile to be the shining star for Colorado. And there'll be more in the RFP when it's released about details on what that means. Promote strong community partnerships between behavioral health and other relevant providers, including hospitals. And I mentioned this. You go to the next slide because I think some of the names on the next slide. It's not, but okay. So we have hospitals, we have law enforcement, we have existing behavioral health providers in the community. If you think, for me, like if I think of something like Cortez, right, who needs a crisis center, makes absolutely no sense to build a CSU in Cortez. They're never going to fill it, right? But we still expect that person to drive a really long distance over Red Mountain Pass, and that pass scares me. I can imagine in the winter it's got to be awful, right? Why not look who exists in a region? An ASO can look who exists, including being creative and saying, okay, there's not a behavioral health hospital in Southwest Colorado and Cortez, but there's a medical hospital. I wonder if we can work together, use a bed, and then my psychiatrist, whoever I contract for psychiatry services, could do telepsychiatry with the physician. And we can, instead of building brand new services in a region that's not going to fill that capacity. I think the ASO model is a way forward for more creativity and less restrictions and more opportunities for the world that exists. It could happen, maybe the hospital says no, they're not interested. But at least it's an opportunity that we could explore collectively. All right.
I think I've
Question?
one question here. Hold on, let me get it won't come out. The question is there awareness that the HICS regions are based on not where the person lives, but where they see their primary care provider? Using the same regions, maybe just repeating a problematic attribution versus geography reality. So I'm implying from that, are the regions based on the person's geography or the geography of where they're getting services?
I'm not talking about attributing lives to the crisis system. You're talking
No.
about geographic boundaries for management services. MSO model doesn't say.
Yeah, there would not be an attribution model.
So the comment was around the attribution model used in the RAY regions on the healthcare policy and financing side, and we are not attributing individuals to a region. We're just aligning geographic administrative entities. There was one other thing I was going to say about that, but yeah, attribution is a whole separate thing that I'll let Laurel get into if she wants to. But
Let me say this. This is not HICS RAY fit. I will say that this is not that fit. This program is about being flexible to the consumer. Just as I believe MSOs work together about folks that are crossing lines. It's got to be consumer friendly.
The one other thing is when you're thinking about where an individual is receiving services, it doesn't mean that an administrative entity, right, like just thinks about who's in their region. They also think about statewide, what is the best set of services to put together for my particular consumer, right, of services. So it doesn't mean that you are only providing services in your region, right? Like we know that there's gaps across the entire state in terms of coverage and what's availability of services can be pretty diverse based on where you live. And so this allows, right, like the administrative entity to think about that whole robust continuum and put those services in place, regardless of where they are located, but where they need services.
As a program, that's where we would like to see it. That was not a dig on Hickok's rate bid. It was just that I don't want people getting a freaking, like, they know that bid, right? I don't want people to start getting nervous about that. All the things that apply there apply here. Now, this is its own bidding process and its own program and its own structure. Okay. Any more questions before we move on to the last bullet? Any more questions on the HIC? So I don't know if there's any more questions. Okay. Not seeing any. And the last one's from our missed that one. All right, moving on to the next one. Some more about this. Summer process activities will shift from providers to the ASL. Obviously, right now, OVH is working very closely on provider-specific details. We would like to see the program take a step back. I think I went over this kind of. I think maybe not understand when I said when you say ASL. Great. I think we're good there. Then I think everybody knows what I mean by that. We are trying ASO. We don't want to compete with MSO. We want to, so there's something to be clear. Responsibility for fiscal and data reporting. We need to work together with whoever the ASO is. So we have a complete picture of Colorado, and not just from the crisis funding, Medicaid funding. Right now, we don't really make it. We don't allow people to be able to do that the way it's set up. Now, that's probably going to take more investment on and identifying more funds to make that technologically possible. But I would like to be able to tell a complete story, particularly if we're saying $30 million is not enough for crisis, in addition to all the other funding sources that exist and all the other rules that exist in Medicaid and all the other. We've got to be able to go to the JVC as a department and articulate that. I get a lot of questions about what about this we're funding over here and that we're funding over here and we're funding here. How do they come together? And I got to be able to articulate that, or whoever is a department needs to articulate that if we ever come to the point and say we need more. Okay. I don't know if Carolyn agrees with me, but indirect administrative costs for the ASO will increase. So there is going, obviously we're kind of adding a layer. I mean, this is not a drastic shift, but we are adding a layer, and we know there's administrative costs. But we don't want to see services go down either. So we know there's a realistic burden to that. Two things we're hoping. We're hoping that by having a more robust conversation about other funding sources such as Medicaid and private payers and other crisis services that exist in Colorado, not a part of the crisis system today, we're not reducing. We're being more effective and intercollaborative. And we have also identified funding at the state level that's not part of it's federal money that we potentially could put towards the crisis system, anywhere between $500,000 and $750,000 we could add on top of the money that the JVC has already given us. So we hope to ease the burden of administrative function. We are appreciative of what that is in an ASO, but we also don't want to reduce services. So the funding really is on the service side that we've been able to identify from a federal level. Without cutting anybody else's budget, don't anybody worry. So that's good news. That's a little more money, and we'll continue to keep looking at areas, both state and federal, in which we can keep building out the crisis system. That includes the hotline. Arizona hotline has a system by which they're claiming Medicaid dollars. So we are exploring avenues there about adding Medicaid dollars for hotline calls. So that is programmatically an area that we're looking at as well, wherever we can identify dollars. I don't know if it's doable in Colorado, the way we're structured. We're structured a little bit in Arizona, but it's worth exploring. All right.
2 questions.
Yeah, what's the questions on that?
One is, could you ask how much the administrative dollar cost will be expanding from seven regions to 4? So I'll just.
No. It's an RFP specific.
Yeah, so I just want to let everyone know if anyone else has that question.
You're gonna have to wait for the RFP. You have to wait for the RFP to see how the specific budget components are out there. I will say that we do appreciate the cost of administrative. That's why we're trying to find more money to add into the crisis system.
And then the other question is, if an ASO is responsible for managing each crisis modality, how would the contracts ensure that the crisis line is aligned across the state?
So in any structures, even today, and today, so let's not talk about the RFP or what it's going to say, but today, well, today we set expectations. Like I said earlier, the business rules. We got to set standards and business rules. We got to be better at that as a state, as a department, establish strong business rules and expectations, right? So we're saying if you take these dollars, here's our expectations. Those are the guardrails with some flexibility for local, right? With that said, statewide, would like to see mobile be the shining star of the crisis system. So that's where I'm going to leave that one. There are ways to set guardrails. There are ways through contracting to set guardrails with sitting down and I know we're guilty of this sometimes, trying not to be over prescriptive, right? And figure out what that right balance is of guardrails versus micromanaging. So we've got to work on it. And I think we're doing a good job and a better job with MSOs with that and trying to establish outcomes. There are areas where we overreach and there's areas where we underreach. It's a learning process that we continue to work on.
No, I think that's it.
This one we're working with. This one is the managing performance-based payments. We're open to. We're not entirely sure what this would look like. The conversation we're open to having. At the end of the day, I care about people getting served, as you do, but I want to make sure at the state that people are getting served, and that's what matters. I want to know that there's a certain number of crisis beds in each region. That's what matters. That's what matters to me. When we start getting to payment sources, I'm actually getting a little less care a little bit, so a little less caring and a little more caring with the total number of beds for people in crisis is available in each region in Colorado. So those are parts that matter to me. So we have a performance-based payment. I'm open to that. I know it's a good tool for an ASO with their providers that allow flexibility at the same time to make sure the ASO is getting their demands met. So it's something we're open to having conversations to after the RFP comes out. We can talk more. This one really is how would it look? I really don't know. The program, I don't know, but open to the conversation. And then maintain a crisis network capable of ensuring access and continuing of all contracted services within the region. We as a state have invested, the General Assembly, the JDC, the Governor, Department, our community partners have invested into a crisis system that's there. Our expectation as a program going forward is that we grow and there's no turf wars. I mean, that's really, and I think what I really want, right? That's easier said than done. I get the business, all the business components of how do we interject, how do I provide services and reimburse for it, and that's why I want to stop trying to figure out the solutions, let the ASO figure out those solutions going forward. And so I really, not talking about the RFP, but I'm talking about the program. People who come to the table who want to work together and who want to build upon the successes we've had are people I want to work with. Just in anything, right? So, you good? Okay.
First question.
Yeah, question. Sorry.
So I know we were clearly delineating between rate regions as the geographic boundary versus an attribution model, but I think it is really worth acknowledging that attribution model helps determine how much funding is allocated to each of the regions, right? So is it too early? Is it an RFP question? Maybe, but would be interested in exactly what that distribution looks across that region.
Yeah.
The methodology to make that.
That's a pre-bidders conference meeting. So the question is about how the money could be allocated, and that really is RFP specific. So we're happy to have a conversation after the RFP is out. All right. Yeah. Any more questions in the room? Yeah.
You mentioned something about using hospital beds potentially as crisis beds. As someone who has been hospitalized, I feel like the intent of the system is not how people have that experience all the time. So the idea of like having people in a hospitalization kind of setting or an ED kind of setting, and then just calling it a crisis bed and having services maybe come to them doesn't seem like it's an actual solution. It seems like it's maybe perpetuating the same problem and discouraging people from using the system.
Yeah, I I agree with you that there are other options, right? That was just an example. I mean, if there's a less restrictive setting that's in that community that we could partner with, I agree. Like, let's go with the less restrictive. Like, to have nothing is also a problem, right?
If a person accesses the system expecting it to be one thing, and then, they're getting tricked into something else, that's really problematic.
Yeah, so.
Oh, repeat the question, I'm sorry.
So the question is around, right, like the utilization of a hospital bed or an inpatient psychiatric bed versus some other alternative, and why we might use that as a potential part of the solution. So is that accurate?
Yeah.
Okay. So I think part of this is, right, like previously in a few slides back, we talked about the majority of the investment in the shining star, as we're calling it, of our service delivery we're thinking about as mobile response, right? So we're really hoping that folks will get a mobile response in the community where they're at, and hopefully that will mitigate the need. Though we know that sometimes people need to go inpatient and sometimes they need that level of care, and so we also want to make sure that there's that full continuum of services that are in each administrative region, right? Not necessarily geographically in the region, but is available within the system. And so there needs to be that full continuum. So I think that it is the full sort of robust continuum, and we are thinking about the investment of keeping the individual in the community, delivering in-home respite, ensuring that there's robust mobile response in the community as the priority.
And that's the preference. The preference is the least restrictive and as much as possible keeping people in the community in their home. I don't want to give the notion of that, that's what we want to promote. I'm trying to just give the idea of flexibility if there's nothing in the community about all the other people who you can work with. I agree. You probably have to get more creative. It's not as simple as saying what I said. You probably have to get a lot more creative than that. It could be urgent care. I mean, it could be a number of things that I'm not thinking of. But I hate to see people go without anything because it doesn't make sense to build a whole 16-bed unit in a part of the state, and then our only option is nothing, right? We've got to be more creative. And I think that's where the question about consumer feedback and community stakeholder input is really key, because those kind of statements, I think, are really need to be heard and what solutions that are developed.
I've got a question related to the shining star versus where some of the impacts have been. I think in the 2.0 meeting, frequently we have heard that one of the major changes to the mental health system has been the establishment of the walk-in centers. And so with that, when an ASO arrangement is happening, is there anything within an ASO arrangement that's going to require that the entities that have established walk-in centers are going to be a provider on that network? Or will the ASO have the full freedom to be able to create new, I think it goes back to the earlier question, there's been a lot of establishing of different programs. So I just wonder if you could speak to that.
So I don't want to get specific with what's going to be asked, but I will say that we value all 5 modalities. I already mentioned the building upon what's working, and I also mentioned that we are going to establish guardrails for everything.
Is part of the guardrail that the provider network that the ASO chooses to contract with inclusive of the centers that have already put a lot of resources to establish these modalities, or is that not part of the guardrail?
There are. I'm looking at procurement because we're getting a little bit into that. Like I said.
That would probably be a proper question after RFP.
Yeah. So I will take what you want, but I'll reiterate that stronger partners in any program are those that are going to work with the other people that have invested and are passionate as they are and as I am about building a system. As a state, we do have certain expectations and certain guardrails. As a consumer, maybe I don't want you in my home, right? And I don't like reinventing the wheel for any program for the state of Colorado. So take what you want from that. Yeah.
I'll come first. Yeah. So, Lieutenant Julie Keith with Colorado Springs Fire Department. And I guess I just want a little more clarification, because there is a lot of work that we've done when we talk about shining stars around mobile. I do think Colorado Springs has a model that has not only set the tone nationally for how to provide mobile, but internationally, right? So we've been recognized that way. And so I guess I just want to understand when I have to go back and tell my community, are we going to have to revamp, pull everybody back together to go into an RFP process, or are those dollars still going to be, are we Are we wiping everything out, throwing baby out with the bathwater, or are we, you know, I guess I'd just like to know, do I go back to my community and say we're back to square one around funding and have to be part of this?
Who are you funding with today? Are you funding with the?
With this, yeah, with.
Open Colorado Pride.
So, and this, you wouldn't have to RFP anything as a provider, right? With us at least. You wouldn't have to do anything with us. The ASO and an ASO structure identifies the provider network and works with provider network. Partners who build upon, instead of trying to use money to reinvent the wheel, we are not doing good use of their time on any program, as far as I can give you. I wouldn't worry at this point about those things. It is on an ASO model, there's a lot of authority within them that exists about who's going to make the best provider and best outcomes. I will say the word about your program is getting out. I've heard a ton of the EMT model and co-responder, and it's a very strong model. I think a lot of people would see the benefit of that, but I can't make any guarantees.
Could you just clarify one more point? Why the timing now? When we have an outgoing governor, outgoing cabinet member, and we're in an election year, it feels like a lot of disruptive change and a lot of fear and uncertainty when you're going to have a new statewide oversight. And so I'm just wondering about the timing. Could you please address that?
Can I just add to that the rate for our community, right? So not all of those things, but including the rate that is really disrupted in our community. So there is a lot of changes that we're going to have to try to be able to react to.
Well, the fear is the continuity of care, and how does that affect the consumer? And are we really having a very thoughtful look at timing? It's very frightening, and I think that needs to be addressed.
So a couple things. Trust me, it's been brought up over and over again. Almost all of our state contract, if it's not defined in legislation, is a 5-year cycle. You can add a year on for certain exemptions, but almost all of our bids are in a 5-year cycle. I don't know of other contracts that's not specifically defined in legislation that this person will do that, where it's not. I could be wrong, but for the most part, I'm used. My experience has been contracts of this size are 5-year cycles. The timing with the new governor, I don't see any governor saying we're not going to invest in this. I mean, that's the other thing. It's like this whole switching the governor. I mean, these people are all staying here. They're all moving forward. You can ask them. I'm working them to the bone every day. There's no lame duck, at least in the Department of Human Services. We are moving forward. I don't see a governor coming in and saying, either party saying, let's take back everything we're doing and let's not invest in it. So the timing thing to me is, I think we get too much credibility to the idea that a new governor is going to uproot the whole system of behavioral health, when the effort should be about encouraging people to invest more into the system. I guess I don't see it as disruptive as you're concerned about switching administrations, because all these people are going to continue to work and advocate, and they're not going anywhere. So that's my response to concerns. And I really feel like the ASO structure is allowing more flexibility and less disruption from the state to the ground level. So, other hands, questions?
Well, I think any of those who work with the MSOs could attest to the flexibility inherent to that structure, that if you're not contracting directly with the state, with a second entity, there's just a lot more flexibility.
So one of the providers in the MSO model said that there's a lot more flexibility for them in that model, and results in less disruption, right? The MSO model is not going to get disrupted in a new administration. There's a structure in place by which they're there, they're managing. These folks are working with them and manage them. There's not a whole lot of, the only time that really I can think of the MSO where politics gets heavy is when opioid deaths are hitting the headlines and we're making an advocacy for more money and more flexibility at times. So this would be the first of reducing flexibility for me. All right, and I appreciate it. I appreciate the concern. And it's a concern that's been expressed by others, and it's a consideration that's staying in the front of our minds as we go forward as well. So, other questions? Anything on the web?
Nope, nothing on the web for questions right now.
All right. So, as I mentioned earlier, we need more protocols, and the business rules are not just from the state side, but they also need to be developed on the local side as well. Here are just some entities, but I would want a program to work with. I think I mentioned just about all of these, but they'll need to work between OVH, the ASO, and the local community, and getting local community input, but also how predetermine how we're going to work together. And a lot of that exists. A lot of that exists today. I don't think we know it at the state level, but how it exists at the local level. But we would like to. So I think this is what that's saying, is having ASO coordinate how these groups are working together. What I think all of you feel, and we feel too, is when a crisis happens and trying to figure out how these partners work together after the fact, it's just more frustrating for the consumer. And it makes no sense when we know that these are parties that are going to be involved. So how do we establish and with some flexibility, but establish upfront that these groups are going to interact, and what should that interaction look like as a system? Great. I don't want necessarily, we'll put guardrails to this, but I don't want OVH dictating that to micromanage that on a local level either. So. Warm handoff. When I say warm handoff, I know that has a lot of meanings, a lot of people. I'm just meaning that the consumer who's in a crisis is now trying to figure out where I go next, and they're giving a card. To me, it's not working. So how do all these people, whether it's today or tomorrow, how do we make it both the technology data side, and I'm looking at the OAT guy over there, merge? I mean, you think about the health information exchange, right? As one area, how do we do this as a standard, right? As a standard that we know what's going to look like before it happens going forward. I think that's an expectation. Like, I don't think anybody disagrees with me. If you do, you can follow up with me after. All right. Any questions before we move forward?
Question.
Yeah.
Got one. When discussing the improvement of community partnerships, I'm wondering if communicating or coordinating with a person's PCMP, primary medication provider, primary care provider, is part of that conversation. Primary care is a great venue to both screen the population for mental and behavioral health needs, as well as inform the populace of crisis services. Are there plans to ensure that primary care providers are involved in communications and protocols related to handoff?
That's a great question. Yes, they should be in the conversation. There are a lot of primary care providers, so expect an ASO to know to go up to every primary care provider might be a little much, but knowing what your folks should do in that case is important. HICPOP has invested in this because they have invested into behavioral health in primary care. I'm not going to go into all the specifics of it. So they've invested in and those folks who do behavioral health and primary care, yes, should know how to interact with the crisis provider and vice versa. So although they're not listed here, I do think that's
Rays are listed.
okay.
Yeah,
The Rays are listed. Yeah.
So Rays now, since their change in attribution, have a more manageable primary care network. So
I'm hearing HICPOP's already kind of set that expectation up with the Rays a little bit about behavioral health and primary care combined on the Ray structure. I think we'll have something similar as a program going forward for crisis that in the world of behavioral health, primary care offices that have behavioral health and primary care physicians are part of that conversation. Now, I don't think the expectation is going to be to go to every primary care provider, but understanding how do we, if you have a large primary care provider, yeah, I think it includes the benefit the ASO to do that, to reach out. So
I know that this isn't an all-inclusive list, but it is a high enough priority, probably because it includes the CCD and their provider network.
Yeah.
We do have individuals that link between the two.
thank you, good call.
Yep.
So the question was adding CCB to the list that's on the slide today. And yes, this is not all inclusive. These are sort of just high level folks that we thought of. All right. Oh, Sarah.
My question is whether when an entity for any of these RFP processes submits a proposal, are those proposals, can anybody see those, or does just the state see them? And also, if any entity, regardless of who it is bidding on a process that will impact the community, is there some mechanism that they have to use to demonstrate community support for the proposal?
I will let Brian talk about. Brian, come up here.
Yeah.
The question was really about any RFP process
Right.
and what that looks like as far as stakeholder input and some other components. So I'll let Brian talk about it.
When the state collects.
I'm sorry, Brian's with the Department of Human Services Procurement Office.
Yeah, when the state collects RFPs, what we can do is after we open them, usually after a few days after we close the bid or the RFP, we open up what we received. We're able to give out that information, who bid, but not what they bid. That will not be available until after the award has been made. So we're talking.
You guys decide whether the bid is appropriate, but nobody else can see or weigh in what's being proposed for their community?
Correct. That is up to the state's determination. No. There will be a committee, but that information is not given out on who is a part of that committee.
Okay. And then the second part was, do the entities that bid on these things have some element where they have to demonstrate that they have community support for what they're proposing on behalf of a community?
There are clear instructions in the RFP on what we are looking for. So again, just wait for that.
And other RFPs in history, not this RFP.
I'm not talking about, I'm just in general, like how you
How
know
in
what.
If one were
add a
to,
requirement for letters of support or things like
Yeah.
that, so you're providing input now to the department that you'd like maybe that to be included. And then you'll
We
see
can ask for
in
letters
the
of support.
RFP whether they do or not, but there are mechanisms like that that ask for letters of support from bidders.
thank you. Did
Are
everyone?
these all RFP questions?
Thank you. No, that's.
So RFP process question.
Generic RFP process question?
Generic question.
Let's start here and then go there.
Would you address transparency, and maybe it wasn't intended to be stated that nobody will know who's on the secret committee, and I added the word secret because I like the drama of that word. But will you address the transparency, so that, I mean, if there is a committee appointed, will it be public knowledge who the committee would be, or is it literally going to be a secret process?
It's not going to be a secret process. It's going to follow the same process that CDHS has followed for years now. We just don't identify the panel members on our form. Once we get done with the evaluation and we award it, all that information becomes public along with the other proposals. So yes, you will see how you were rated and the comments and good information like that, but you will not know who said what about you. It will be generic panel member 1, panel member 2.
Yeah.
Really not
Oh,
sure.
Jason was next, I'm sorry.
Just real quick, this isn't an RFP question, it's really more of a request. Historically, the state, when they've done forward with different RFPs and different changes, there's been a time in transition for a bridge between what has been established to what is going to be established, and sometimes that's an impact to some of the providers within. My hope is that something is inclusive enough that would allow for us to be able to bridge if in fact something does change with because we have essentially a provider network, and I just want to make sure that if we can, bridge for some time frame to allow for them to be able to step through to move that forward. So it's really more a request, and we can't respond to that, but thank you for the past, and I would ask for it in the future.
Noted. Sarah.
Sorry, I'm really not trying to be a rabble-rouser.
Yes.
I just want to point out that these decisions, these bids for various things have really big impacts on communities. And a lot of county government entities or other, family resource centers or people that are very integrated in serving our communities have no idea what's being proposed and have no input or no recourse, really, once the decisions have been made. So I would just say that it might be helpful to ask that anybody who's bidding to provide services for a community or region be able to demonstrate that they've vetted their proposal and have community support for what they're suggesting.
Noted. All right. We can't talk about the RFP, we can't talk about the committee, we can't talk about, but I'm hearing a lot about stakeholder input and community input. I'm going to talk generically about how I feel about that. I value it a lot. I've not always been great at doing it, and sometimes moving at 120 miles per hour, and sure, so even this can attest that happens. When I have time to think about it and I have time to breathe and think about this, I think team that has time, really value stakeholder input, and as a psychologist, I also understand bias. So taking that into account in any decisions we make as a department, as an office, anything we do, also bias is taken into account, and I like the most objective information possible out there to make any decisions for all decisions I make on behalf of the office of behavioral health. I'll say that. Okay. Is there another question?
Data technology?
Yeah, this one's weedy, but I'm gonna go over briefly the RFP and the contract process. We'll really get more into detail, but we need better data. I think everybody agrees we need better data. Not as a fault to anybody, but it's just the structure is not set up today. I would like to know that any partners that we work with in any program, if we were able to evolve and grow and get resources to be stronger on the data and technology side, I hope that all our partners would want to participate. All right. Client level data, we got to be able to follow people, not we, I mean collectively, and know that somebody got what they were supposed to get, or nobody fell through the gap. So somebody's already working with somebody, and instead of me paying for my provider, this provider over here to have to duplicate services they've already provided to work with. I think it's pretty straightforward. Health information exchange. As an office, we are moving towards health information exchange. I think most of you are as well. There's just too much value, and this is something I feel like for at least the last 15 years, 20 years that we've been talking about how do we medical homes and how we get data together and health information exchanges. Technology is finally there. I think it's easier, it's cheaper than it's ever been. So want the program to move with that. Obviously, the MSO structure now, we have a lot of administrative reporting. In the crisis system now, we have administrative reporting that will continue. I think the biggest challenge is going to be the connection of folks that's from the hotline to the mobile and the mobile to the others, and just being able to follow folks. So there's going to be a challenge that we're going to have to discuss and figure out the solution after an award is made about how that happens and how someone calls the hotline, how are we able to connect, because they're going to be separate systems. So how does that? Any questions on this? It's pretty straightforward. I know we don't have all the resources today to achieve that. I mean, as a program, I'm not going to expect folks to do things that we don't have the resources to do, but I want a willingness for when that day comes, if that day comes, that we could do. Yeah.
For mobile, do you envision the program dispatching mobile at the regional level?
Is mobile being modality at regional?
Dispatch. Will the dispatch be mobile? I mean, it seems like what you presented on mobile services.
Can you have other entry points other than the statewide hotline? Is that what?
Yeah.
Who tells mobile where to go?
Okay, so there's a couple of things there. One, we do not have a conversation. We will look to the ASO to explain how they would do the mobile in the region, for their region. There's going to have to be standard. We're going to have to standardize a little bit more, because I think there's validity on both sides, and better understanding why we don't go out when we do go out. And I think we need a standardized process. Yeah, I think as a program, we need a standardized process that's not overly restricted for mobile. So when you think about stepping down, right, hotline should be self-defined crisis. Mobile has standardized. It's probably not quite medical necessity that we hear a lot of complaints in the community that they can't get service to medical necessity. So it's somewhere in between, a little more rigid for inpatient. You got federal laws to consider and other things to consider. So it's probably going to exist somewhere in there. Really open to that conversation, what the standards would be. I don't have all the answers to that. Really looking for people to come to the table and talk about what is the standard that should exist for a dispatch of mobile. There are two areas for mobile. There are two areas for mobile that I do think we need to be a little more prescriptive on. Law enforcement calls and says, I really need someone to come out for behavioral health. And there's an area that I don't know where it falls because of resources only. A lot of other states, if a foster parent calls you and says their foster kid's in crisis, the mobile has to respond. I don't know where I am with that. I'm open to conversation to that, but I love the idea. Love the idea. The state of New Jersey, they put that in place, and they have seen their out-of-home placements get. These are foster parents asking for a real help. They love this kid. They want to keep this kid. They just need to mitigate the crisis in the moment, particularly because there's often other kids in the home. So this is where respite and mobile and opportunities can come into place. I'm not quite at the we must go, but really love that idea. It's something I'm strong on, but totally open to how that would look and how that would work. So that's when we need counties at the table as well. All right, paired mobile. Yeah, I'm open based on risk factors, right? I mean, you kind of, from a liability standpoint, one person going to a home period is probably not the best approach. But if you're going to an emergency room or you're going to some place where the professionals already exist, you probably don't need two people. So just developing the business rules around mobile will need to occur at some point. Community response, I think I mentioned this. This is tricky. I know there's a lot of debate in this in the committee about community response, where mobile goes. And there are times when mobile should go to ER, and there are times when it's probably not the best use of resources for that community. I think we need to really lay that out and what that looks like, particularly being sensitive to rural communities that don't have behavioral health specialists in their hospital or anywhere nearby. Really trying to lay out what those standards are and just being on the same page, I think is going to be critical. And there's a value to it, but with limited resources, what should be prioritized? Where should people go? And again, we really want the remote community living, staying in the community, staying in the home, staying where people are at as much as we can. I saw a hand up over here.
I just want to ask, are you also going to be factoring in telemedicine from the rural communities on some of the mental health evals and assessments? Is that still going to be a practice, which some of the ERs are doing? So if that would be the offset of not sending a crisis response to a hospital because you could do it through teleservices. Is that still a factor?
I think other funding sources, including Medicaid, are invested in tele, and that's not going away. And there's a lot of value to tele as a program. And I appreciate the creativity that has to occur and the technology that has to occur in rural regions. So I don't think any of that's going away. I think it's a conversation that needs to be had about what that looks like. And if there's an opportunity to use technology with limited resources to serve more people, use the technology, right? Now, to be honest, the one thing with tele though is at some point, for certain situations, it becomes not desirable to the consumer, right? We got to balance with, I wish we could all do face-to-face, but we can't. It's the best we could do for, wherever it may be in Colorado, versus doing in-depth therapy sometimes where you want to connect with the person as a consumer. You got to weigh all those things.
Well, unfortunately, that's still happening a lot right in the metro area, so certainly it would be more as you disperse out.
Sorry, I didn't repeat the question. The question about the use of tele with crisis, and we're going to continue to promote. Jason.
I've been a little concerned that I think that the state has fractured a bit in the way the dollars have come through for both mobile in this kind of arrangement, and then also what came forward with $207 with the co-responder model. So I guess my question is that is the $207 going to be under the ASO as well to be able to make sure you've got fluency between all of that entire mobile response? Because I do think that there's a gap in the way that that's functioning, and that would be, I think it'd be an improvement actually. Yeah, I'm looking at the, can we say what funding sources are going to be under the ASO structure?
You already said that you were not going to.
We can't talk about budget.
Okay. We can't talk about that.
So I'll just tell you that the system is fractured and it needs to be repaired in terms of that. And if this is the way to get there, then that makes sense. So I will say that.
Noted. Thank you.
All right.
I think our behavioral system as a whole is fractured.
Right.
So again, it goes back to how do we collectively integrate and not reinvent the wheel for anything we're doing behavioral health. All right. We talked about MOUs earlier in the list, setting up sort of prearranged arrangements so we're not figuring out things in a crisis after the fact. We know where people are going to go. We know which cities are going to be interacted, and we will want the ASO to set up sort of guidelines for that, so you know who they're interacting with. We also want people to be followed up. We'd like to see people followed up on in which mobile responded. We could talk about what that looks like with the winning bid and what exactly what technology we need or what technology isn't needed. But following up, making sure that somebody was able to get the services and not, you know, almost all you know that some clients need a little nudge to follow up to get the service that they would recommend. Again, how the crisis line and mobile is going to work together and what the standards are. It's a major liability to have those two disagree about going out, and hasn't been so far. But it's a little bit of a liability. We're going to have that conversation about how do we mitigate as much as possible that liability where two entities are assessing and disagreeing, and what are the standard rules for that? ASO and hotline. I mentioned the triage protocol for mobile response, and mentioned child welfare and law enforcement and setting up standards for that. Okay. Anything on the?
Hi, Carol Meredith is the Director of Douglas. So, I have two questions. Some local communities have already started setting up their own systems around this because they couldn't wait. And so how are you going to integrate this new sort of state approach with what local communities have already developed?
So I think that's the purpose of having it.
Oh, we can't hear either.
Oh, sorry. The question is, some local communities are building structures for mobile response. For example, Douglas County has a community response team that they invested a lot of local funds into. There are 12 people doing community response pilots with the state now, co-responder pilots. I think that's the appeal to the department of an ASO is it's a step towards stop billing parallel services. Now, getting to say who an ASO contracts with, that's a little tricky, and I don't. That's where we really, I don't know. The MSO has been great about identifying existing people in the community and lending funds, because it also makes it easier for them to meet their goals when they're using other funding sources. And I know the counties are eager, and I know the providers are eager to make sure they blend. So I think that's the point of the ASO structure. I think partners who are willing to take a step back and identify that are strong partners. And I can't talk specific about the RFP though.
Yeah, that's fine. But I'm worried about the data systems and the health information, and people are putting some money into these management software and those kinds of things because they just their communities are really in crisis and need support now. So it's
specifically
integrating those systems, in my experience, has not been very successful.
So the question on the phone, in the room was not only integrating services, but the integration of data. People spending money on data systems, and I agree wholeheartedly. And I think Camille's been working really hard, connecting with jails and trying to connect with counties to talk about the health information exchange and a data integration project. And I don't want to get too much into it, but we agree. And so what OIT and Camille have been working on with our partners is identifying what this minimum standards system needs to have in order to be connected to the health information exchange, which is an exchange of information that if everybody invests towards that, we'll be sharing information. And if there are people who are in the community who are not part of the crisis system that are looking to invest in systems, they should talk to their partners. They could, after it's awarded, they should reach out to the ASOs and say, hey, we want to invest in this, but instead of us investing in a separate system, can we invest in something similar to you're doing, or all this kind of things. Obviously, HIPAA, there's all those other things. They should get together. We are promoting that for the Health Information Exchange, the Data Integration Project. And if folks want, and folks have to sign up for our listserv, where we put all these things out. If you're not signed up for the OVH listserv, sign up for it, because it's where we send all the information out. And you say, oh, I need to contact the person because I don't want to invest in a separate system. I'm going to move forward because we are running out of time.
I just have one other comment.
Yeah.
For children, I would not make it just child welfare. I mean, we have a huge suicide problem going on everywhere, and it's not just kids that are in child welfare, and I think
Wholeheartedly.
that feels biased to me in the child welfare system. We got lots of kids who need support.
Yeah, I'm sorry, the room was not, the question was not to focus on just child welfare, and I agree. I agree, it's not just child welfare. There's, you have a lot of kids in youth corrections that it's really up to the judge which direction, what system they're going in. A lot of kids on probation, a lot of kids in schools, right? So that work doesn't stop here. I agree, there's other areas that we have to be all inclusive as well. Yeah, so I'll leave it.
We could prevent child welfare if we did a better job on the other side.
Agree, and that's where Children's First Act wants to go. Sorry, another question over here.
Okay, real quick, you mentioned on the previous page about concern if the crisis line and mobile team isn't aligned. Has there been any discussion, and is there an opportunity to combine both of those? Is there an opportunity?
That would require either both being statewide or both being by region, and there's been a lot of internal conversation about that, and this is where we landed. Okay, as a program, that's where we landed.
Program.
Yep. All right, walk-in. As a program, we do want to see one walk-in per region. Well, this is not in stone. I don't know if we move from 4 to 7, what that looks like, but we would like to see each region have some walk-in capacity. When I'm talking about creativity, that's about CSU beds earlier. It also applies to walk-in concepts, right? People have good partnerships with urgent care. They have good partnerships. Not everything needs to be built, right? Some of it needs to be aligned. So think about walk-in. And again, not a fan of reinventing the wheel. So that's where I'll leave that. Leveraging AXO to expand network capacity rather than expanding actual brick and mortar, I just mentioned that. I really want to allow you guys to be flexible and creative and think about urgent care and think about where people are already going and can we do assessments on the spot without being really clear about other, and I got to emphasize this, and this is not pointing fingers, this is us need to be clear, that as a function of mitigating a crisis, not a function of an insurance payer requirement. Right? Obviously, it's a requirement of this crisis, right? What information we need, but I really want to mention that. Am I opposed to someone who says I could build a program that does both and I can combine resources for a maximized effect? Absolutely not, right? From a program perspective. If you're a program if we could build a program that connects everything that exists in Colorado and connect it, all for that. We talked about EDs. We're probably going to have, whoever wins, we're going to talk about medical clearance, and it's probably a conversation when people don't win. Come back to the table and talk about medical clearance after there's a winner of the bid, and talk about staff. We put 2 staff here. It's sort of the current requirement. There are some questions about what if that person leaves to go on mobile and all that other stuff. I think we need to get clear on the same page. Don't overread into this. It's just saying that we need to get on the same page. CSUs, they're different here. So one of the things that we like to see the program and discuss as a program, there's a lot to be fleshed out, is tiers of CSU reimbursement, and I'll let you talk a little more about this.
So in thinking about the full continuum of care and capacity, so within our current licensing structure, there's a variety of services that are offered in a variety of ways. So it's really getting at standardizing what that set of services is. So we know that in communities, we need the ability to do seclusion and restraint, be able to do emergency medications, and then right at the other end of that continuum, it might be an observation stay for a short period of time, and then the person has a transition plan to go back home. But paying one way for that full continuum doesn't necessarily make sense when so it's really clearly outlining what each of those sorts of levels are within a crisis stabilization unit. And so it's coming to the table and really having that weedy conversation and how do you leverage investments in detox and what does that look like as part of the continuum, and making sure that we clearly have defined sort of bed capacity by region.
Great. And like I mentioned earlier, although our main goal is to keep everybody in the community at home, and particularly kids with their families, that's not always doable. But we also know that licensing and the probably something will never, probably won't change, is mixing adults with kids in certain settings. Not all settings, some settings have that, but some settings don't. But allowing the ASO to get really creative about beds for kids, and knowing that sometimes in every community building a brand new structure or doing a whole 16-bed unit is not going to make sense. Who are the other partners that already work with kids and families, or well, kids and youth, and how can they help and contribute and be a part of the solution for crisis in Colorado?
Just going to the earlier recommendations about seeing greater integration of mental health crisis services with substance use disorder services, and knowing the licensure challenges with all of that, can you just give a quick update? Basically been checked out a little bit on that conversation of where we're at with some of the licensing stuff to make sure we can actually combine some of those modalities.
Yeah, I'll let Kristen talk more if she wants, but I know November 1st, oh, sorry, the question was about pretty much where the licensing task force is at with combining substance use and mental health. Licensing task force is working. I know that almost everybody in the room agrees that it doesn't make sense the way it is today. By November 1st, that they want to have a report so we get ahead of the legislative session in case any legislation needs to change, and the task force. I think it is moving in the right direction of integration, as long as it's not, it really is asking the question, when this was put into place, this rule or this law, it probably was for public safety, or probably was for concerns about funding. Is that really true today? Do we care that's about separation of funding? And if it's about safety, were we over-worried, under-worried, is it right? Were we just being paranoid, right? I think they are having that conversation. I will say I think it's going in a good direction towards making sense and being pragmatic for the community of Colorado. That's good for you? November 1st, right?
December 1st.
December 1st.
And serving people with co-occurring conditions is actually one of our principal things that we're trying to address in the county board.
You can email Kristen if you have more questions on the licensing stuff. She's sitting on that. All right. And then if there's not available in the region, let's say somebody lives close to this kind of came up earlier, somebody lives close to the edge of an administrative line, it's quicker to get to some place that's next town over, but it's in a different ASO region. Really expecting ASOs to work together and have ASOs working not only together, but be able to work with providers in other regions to allow for that. This is going to have to happen. I mean, the regions, but particularly Larimer County has shifted. So, and there are mountains everywhere in the middle of regions. And so, we're really going to have to be willing to work together and not only contract for folks as an ASO, work with other ASOs, but also be able to contract with providers that are in other regions to make sure that people that are getting care for. So, all right. Next slide. We talked about respite quite a bit actually, and really wanted to prioritize in-home, understanding that some facility-based respite care is still needed, particularly for youth that don't want to be in the home. Priority for persons with IDD and for children and adolescents. I really wanted to see services there and making sure we are reaching out to folks that are at risk and vulnerable. Care necessary to eliminate the psychiatric crisis. So what is respite, right? Is it to address homelessness? Not with this funding source. With this funding source, it's to mitigate a crisis. Now, that person may be homeless, right? But it's to mitigate the crisis. And I think just, again, it comes back to us as an office and as a department, establishing clear business rules so we're all starting on the same page. And I guess not starting on the same page. I think we're often on the same page. Addressing the nuances and the complexities that exist. All right. I may be wrong around that same page, but I'll assume it. ASO will establish the respite assessment criteria. As in all modalities, we need to be on the same page about what's standard for assessing and admitting for any service or providing service. Okay, next slide. Oh, hand. Sorry, Sarah.
There was discussion on the crisis steering committee about, in terms of the continuum of care, people who are in crisis and hospitalized in some way or in a more restrictive environment and then going back home, and sort of how to reintegrate to avoid another crisis happening very quickly. Is that included in terms of I know we discussed whether it was either crisis or treatment or aftercare and where that falls.
I I think it's included. We're going to have to be really specific in some of the business rules because there are other funding sources as well, right?
Can you repeat the question?
Sorry, the question was stepping down from a higher level of care in which you originally went to, like let's say you went to inpatient or CSU, you went there because of a crisis. Can respite or be used as to prevent another crisis? It's something we're going to have to work out because there's actually really limited resources for respite. So I'm not opposed to it. I just think we need to work out the nuances. I also think we need to make sure that we're using all other funding sources first. And then I guess how you define preventing a crisis, like how do you know a crisis is going to occur, coming up with those standards. I'm not opposed to it, but I think we need to come up with standards of what that looks like. How do you know a crisis is going to occur based on what criteria?
Right, I just heard a lot of people saying that in their communities, and I know it's an issue in our community, that sort of transitional.
And the other thing is we have transitional funding as well in the state. So this goes back to making sure that we are not duplicating services, but complementing services. So I'm not opposed to it as long as we're not stepping in for another funding source that exists to provide the same service. It just doesn't seem like a maximization of funds. Questions before we move on? All right, I think we're almost there. All right, crisis line. Provider wants to adopt the health information exchange based on additional funding as available. As I mentioned, we know some of this is resource dependent. Be willing to participate in the health information exchange if funding is available as a program. The program will be required to protocol communication between crisis line mobile. We mentioned that it's needed today and tomorrow. Having all being on the same page about what that looks like, and willingness to bill for services if we get there, and we're able to do that and not leave federal dollars on the table. And time-specific follow-up requirements. There's also, I know that Hotline now does follow up with folks, and just continuing on with that base follow-up based on written. Any questions about this? All right. Additional items. So this is the last slide. I mentioned that we want to invest more into the crisis system. So we will be doing that without cutting anybody's budget. Mobile response, the shining star, mentioned that already, and integrate crisis with other departments in Colorado to result in the largest crisis network possible. At the end of the day, that's my goal. My goal is to have how can we get the program to be the largest provider network and the most access for the consumers on the ground? And that's going to have to be a partnership. It's going to be a ton of partnerships. I don't have the time to do all the partnerships, so I want an ASO to do all the partnerships.
Robert, how many mental health grant dollars are going to be dedicated to this?
Well, not to this, but we are investing $500,000 to $750,000 into the crisis system that are not from the General Assembly. Yeah, towards the program as a whole.
Okay. In the 2.0 meetings and all those weeks of meetings, there was never an introduction of the ASO as even a concept. Even when you outlined what the outline of that was, I guess I'm just struggled with the feedback from the community. Is this the only time that the community is going to have input into that element of this, or not? Because it just seems like that was something that was introduced and we had all of that time to be able to develop.
So this was not conceived during the committee time. That's what, for starters, it was sort of a reflection back, even though it wasn't a recommendation, it was a reflection back. We heard a lot about Accessibility Network and other people that want to come to the table and help out, and community stakeholder input, and knowing the bandwidth of the state and the layers that come with the state for contracting. Felt like this worked well in the MSO model and how we could get there. This will be on the webinar. There will be opportunities to provide just input to the program as a whole. I would do that quickly. But yeah, this is the first meeting, and this is why we put this out to the world to show up. You might go home and want to think about it and digest it, and then send something back. But once the RFP is created and posted, the only input will be through the RFP process. Anything you want to say about that procurement that I didn't get?
Oh,
okay.
We'll be working through me.
Sorry, the question was about input into the ASO structure, and yes, this is the first opportunity. And if you on the phone want input, we are going to post emails.
Yeah, it's up there.
Okay. Oh, the email's out there. Email Chris with specific to this. Your input and your feedback. I love all input and feedback. Even if I look like I'm not taking it in, I'm taking it in.
Will you just quickly address, will there be any allocation upcoming in the, what we're not talking about today with 3 letters RFP, regarding the raise are already providing a reduction of financial compensation to many of our mental health services throughout our state. And so now, is this going to be putting more unfunded mandates in some other ways that you have systems that are already trying to right themselves? And will there be any allocation of how the management of the continuity of care takes place when it feels like that disruption is still really on chopping block?
So, a couple things. I didn't hear unfunded mandate anywhere in here. And I didn't hear, we were very clear to say if we were adding anything, it was if resources were available. So I want to be clear that I didn't hear unfunded mandate in there. I heard better business rules, and things like that. I'm not aware of unfunded mandate in there. If I'm missing it, let me know, because that's not how I'm trying to come across. I'm trying to say that if we are asking for something new, that like technology or data collection, or it's not that you can't do today, but within the money that we have available for crisis, then we're not asking it until we're just asking willingness if we have the money. So I'm not hearing unfunded mandate in there. And this is about the crisis system. I get that the raise, people are still working out the raise system, but my responsibility is also funding the crisis system, not the Medicaid system. So I know that's working itself out. Medicaids are not the only clients here. We have an obligation for with this funding for all Coloradans. So, yeah. All right. Were there other hands? Yeah.
I guess I just need a little clarification, because I'm kind of with Mr. Wayne on this. This is our opportunity to give you input on how we feel about the ASO, or is this?
Yeah.
Okay. So.
And you can email later, but if you want to say it now, say it now.
Yeah. So I think that I just want to reiterate that from us, from the community that have things that are working really well, who have all their community partners in place, and have systems that are the shining standard for our community, that this does feel very disruptive, and it feels like we're going to have to go back to the chopping block to go through some RFP for something we already have. Kind of like Dr. Khan said, we put a lot of work and energy into what works for our community, and I feel like we're going to have to go back to the table to do some RFP for something that doesn't need to happen for our community. I realize that there are pieces of this that need to be fixed, but I feel like you're broad brushing. I feel like you're just taking everything and keeping it into this corner to make it all go back to the table for the RFP. And I was with the program when we did this first time with the state, and an RFP went really bad. And then we all had to go back as the community, go back to get those dollars back, because as you were mentioning, sometimes the community input isn't there. So what feels really good can't be cookie cut. And so it feels very.
I'm going to repeat what you said for the phone. So there's concern that the ASO is disruptive to the community partners who are already working with it. I can't tell you, there are quite a few community partners who feel like they're not a part of it. And that was also motivating for us to move to this. I get there's a fear there. I get that. I think the strongest partners, though, knows what. I'm not telling people what works in the community. I want the folks in the community to tell us what works. And if there's something today that works, I want them to tell us through the process that it works. Because there are a lot of communities that also feel like Douglas County has community. I'm not speaking for them, but they have community response team that's not part of the crisis, right? I think Eagle has a paramedic thing that they're trying to do that's not part of crisis. There are a lot of models and co-responders that's not necessarily part of crisis. So yeah, there's some dependence on the ASO to want to be willing to work with the community partner that's there today. But strongest partners are the ones that are willing to work with things that are working. So.
I have a question related to with everything, and I'm sure that what you presented is I don't know in the current system how much money is available for what I would just call training. So if it's for the mobile crisis teams, or if you
will there be dollars set aside for training related to how you create those beds in a rural hospital and staff them appropriately with folks who understand how to best provide the needs the patients have. And the other piece that I didn't see in here, but I don't know if part of the current system or part of the new one is, how do you evaluate, what's the evaluation process for patients, for clients, for members who have been in the system to give feedback to your ASO or even in your current model, so that you know what their experience was, how it worked for them, how it maybe didn't work for them, and understanding how the funding is for both training and then assessment.
So there's two parts. There's training and assessments. And training about, it sounds like a lot of training about how you create the right solution or how you interact with folks in settings that are not behavioral health care today. Is that?
Yes.
Okay. Yeah, we don't want to jeopardize anything by putting somebody, giving services in a setting that's not appropriate. I don't know the answer. I know there are training funds and we do training. There is going to be an expectation that, one, you don't put someone who can't provide the care, right? Doesn't know how to provide the care. Absolutely. And like I said, the hospital thing is sort of just a out there idea that someone has.
Right.
But I don't know off the top of my head that the money that's dedicated to it. I know there are trainings. It's something we do need to consider. So I'm glad you brought it up. So we will consider that. We have other funding for training, so we probably should take a look at that and make sure. So we'll work with those local partners that are already doing this. The second one was what again, sorry?
Assessment specifically of individuals, not of the providers, not of the mental health centers, but actually the people receiving the crisis.
It's a lot like the community one I'm hearing, but it's from a consumer perspective, and it's noted and it's important. Other questions?
There was some discussion about dually diagnosed in terms of substance abuse and mental health. There's another dually diagnosed population, pretty much smaller, but IDD, autism, and mental health. And we've had a 25-year history of mental health centers turning that population away.
But it's noted for crisis. We're not going to distinguish on that, but that's a Medicaid conversation, that's a payer source conversation that's larger than this room. So we can give you a name to follow up with, but I don't want to get there here. But for crisis, it's for any Colorado that calls with a crisis. So, other questions? I know not everybody's going to be happy. I have a lot of faith that this giving more flexibility, identifying strong people who appreciate strong partnerships, people who don't want to create the wheel, will result in a better crisis system. And for folks that are in the community providing crisis services, once the bids win, go make your argument why what you do works. And if it works, I have faith that it will be considered and a part of the solution. So, all right. Thank you, Kristen.
Housekeeping real quick again. You all have comments, they'll go to Chris Miller, so you can send those and we'll make sure to review those. And then if you haven't signed up for the ODH newsletter, again, ask Liz Owen, she'll send you a link to sign up. This is where we're going to be making a lot of announcements and sharing information. It's where you can get the most up-to-date information on some of these upcoming things that are happening. So I just want to highlight Liz Owens is the person. You can always ask me as well, Chris Bates, if you have any questions about getting our newsletter.
All right. I assume I'll see many of the pre-bidders conference when that happens after the RFPs.
Thank you.
Thank you.
Thanks, everybody.